Hi, everyone, and welcome tonight to our PCOS Facebook Live. We're going to be talking with Dr. Kenneth Gelman of IVFMD, and he has really been working with some of our patients for many, many years who have been struggling with PCOS. And I'm really happy to have him here to kind of pick his brain and answer some of our burning questions regarding some aspects of PCOS that could be really difficult to explain. For those of you who don't know what PCOS is, we're going to go into detail about that a little bit, but maybe you have a friend or a family member who has just been diagnosed with PCOS and you want to know a little bit more about that. And perhaps you just have some questions because you just found out that you have PCOS and you want to know what the best ways are to treat it and basically get an idea of if you're heading into a medicated cycle, what might be in store for you, and what are some common misconceptions that people might be telling you about PCOS or that you might be reading online. So without further ado, I'll go ahead and introduce Dr. Gelman. Welcome, Dr. Gelman.
Good evening. How is everybody out there?
Great. So tell us a little bit more about your background. Like, what made you interested in working with PCOS and reproductive medicine?
Well, what happened was, when I was initially training way back when, last century, in New York City, I was at Mount Sinai Hospital in New York City as a fellow. And the endocrinology department back then was, essentially had the reproductive endocrine department as part of it. So, we were essentially the reproductive endocrine fellows that basically took care of all those patients back then. And one of my main professors there was a gentleman named Walter Futterweight, who is quite old now, but he's really written all the original textbooks on PCO. Mm-hmm. And so he was, I was learning from the actual, person who actually defined PCOS and researched it. And also there was, actually who's back there now, is Andrea Dunaev, who was a PCOS pioneer. She came from Harvard, and now she's the chief of endocrine at Mount Sinai Hospital. And she was also one of my professors. And then, we had some of the early reproductive endocrinology OBGYN professors there who were part of our department too. And, as part of all our training, we were seeing all the patients in the clinics, the reproductive endocrine clinics. So we ran all the stimulated cycles. We actually were involved with IVF in the beginning because it was just starting when I was there in the 80s. Mm-hmm. So it was our input and OBGYN's input at the time before it actually became solely an OBGYN specialty. So that's where my interest came. Mm-hmm. And I had extensive experience in it because I've seen a lot of it back then. And we were now first getting involved with insulin resistance back then, but weren't treating anybody with medications yet, like metformin yet. That came later. But we, as fellows back then, really kind of had a lot of PCOS patients in our clinics. So we really knew about it. So when I came down here in practice, I sort of naturally gravitated to that. And, I felt that was my main area of interest and specialty. And that's where I sort of picked up my whole reproductive practice from there because it grew from PCOS. And I think, most reproductive people now these days probably see a good majority of PCOS patients in their clinics. But that's where it came from. So, that's where my interest is. And that's why I see a lot of patients with it. And I have a lot of, joy taking care of these patients because, I think we've really helped them over the years.
Definitely. And being a reproductive endocrinologist, you kind of put everything together, not just,
Yeah, because we have, we had a lot of the endocrine background in addition to the OBGYN mm-hmm. background. So it was a little both. So I think that's the best, those patients are best served by physicians who have that background, I think.
Mm-hmm. And can you explain to us a little bit about what is PCOS exactly?
Well, a lot of people, say, oh, I have PCOS, or I was diagnosed as having PCOS. And the definition of PCOS is changing all the time. Mm-hmm. It's changed since I was initially taught it back then. I mean, most doctors who learned about PCOS learned that the classic case of PCOS, which is generally an obese woman who has evidence of male hormone excess clinically, meaning that they have obvious, extra facial hair or acne or hair loss in a male pattern. They generally tend to be obese, and they tend to have what's called central obesity, a lot of them, where their abdomens are sort of protuberant in a way, and they may have, thinner extremities. And it may look something like what's called Cushing's syndrome, which is a different endocrine problem. But, the classic woman with PCOS is noticed on the street usually by a lot of people. And those people also have very irregular cycles, or they don't get any periods at all. And, when you do an ultrasound on them, they have a classic pattern on ovary morphology called a polycystic ovary, which is called a necklace sign, where they have little tiny follicles or cysts. Now, that's a misnomer that a lot of people think, oh my God, I have cysts in my ovaries. Well, they're actually little follicles that just don't develop.
They're not really cysts, right? They
are cysts, but, and there are many types of ovarian cysts. These are one types of very small little cysts. But they're really follicles that basically just can't develop because they're stifled because of the hormonal problem that's occurring there. These little follicles don't develop once a month like normal women would ovulate. On the 14th day. These women don't have that ability to do that. So they accumulate these follicles, and it ends up being more in a peripheral pattern on the ovary. And in consequence, in the middle of the ovary, it tends to have a lot of the male hormone secreting cells of the ovary, which women do make male hormone, and in PCOS, they make an excessive amount of it. So that's where the male hormone secreting cells seem to be, and then the follicles tend to get pushed out to the periphery. So we tend to see that on ultrasound, and when a doctor does an ultrasound, we tend to look for that pattern. And, it's supposed to have a specific number over 12 right now of these little follicles arranged around the periphery. But that's going to change because of the newer ultrasound machines that are a lot more, have better penetrability, and they have better visualization. So that may actually change to increase to about 25 per ovary. They're actually going to be changing that basic definition of what a polycystic ovary is. And also because we don't want to overcapture too many women who may have polycystic appearing ovaries who don't have PCOS. And that sort of goes into this, what is PCOS problem? Because I think there are a number of people out there that may be diagnosed as having PCO, particularly if they're younger, and they're seeing their pediatrician at a very young age where they're getting a very irregular cycle, and they're 14 years old and they're getting cycles every 3 or 4 months, and their ovaries tend to have a little bit of a polycystic pattern. Well, that may be normal. So sometimes these patients are diagnosed as having PCO way back when, and they may outgrow that whole problem, and their ovaries may not be so polycystic in a couple of years. The ovarian volume actually changes as you get older. It's actually larger then. So one of the other things we tend to see in women who really have PCOS is a larger volume ovary. But even in adolescence, the volume of the ovaries tends to be larger, and it gets a little smaller as they get a little older. So some of these people, who are teens, are diagnosed as having PCO, and they may not really qualify as having it.
That's interesting.
So that's one of the reasons why this definition may be changing as time comes.
So the current definition is basically 2 out of 3 factors. Characteristics.
Yeah, the basic definition, as of now, there was something called the Rotterdam criteria that came out in 2003. They actually came out with 4 different subtypes of PCOS. And they defined it by your periods, by your ovarian ultrasound, and by your male hormone concentration. And note that weight is not an issue or a criteria here, because there are a lot of women, probably a good 40% of women who are very thin, who have PCO based on these new criteria, who, you know, don't fit the classic pattern that I described that most doctors learn in medical school. So actually, of the three things that we just described, periods, ovarian ultrasound, and androgen concentration, there's 4 different subtypes in each. So within the period group, there's 3 subsets that could have irregular periods, and 1 can have normal periods, actually, and you could still have PCOS. In the ones that have normal periods, though, they usually have polycystic ovaries on ultrasound, and they will have high male hormone concentration. So you can see that there are subsets of PCO patients out there who can have normal sounding periods. And yet their doctors may say, nah, you don't have PCOS. You know, you don't have irregular periods. But if they look a little carefully and they look at these different definitions, they may actually qualify. And yet there are other types, you know, most of the other types are described, usually had irregular periods, but yet there are some that don't have polycystic ovaries on ultrasound. But yet their male hormone concentration is high. So they've got to have a couple of those criteria, you know, at least. And now I believe that the newer definitions of PCO to include more antral, you know, more cysts, like I described, will also include the actual presence of androgen excess. So if you have androgen excess, either clinically like extrafacial hair or hair loss, that is a very potent physical sign that you have PCO. Acne alone is also not a definition of PCO. In other words, some patients may present to OBGYNs or to dermatologists at a young age with acne. And the dermatologist says, oh, you must have PCO. And they kind of put this definition in there. And they may not. Acne is not part of the definition.
How do you feel about a teenager given birth control to help with acne or help with the, you know, maybe the, you know, strange cycles that they're experiencing and all of that, and maybe, you know, not being told that perhaps they might have PCOS?
Well, yeah, that's pretty common, actually. You know, sometimes the pediatrician may not want to stigmatize that patient, you know, and she's, you know, mid-teens or, you know, whatever, and she's stigmatized by having acne and, you know, maybe having irregular periods, and the pediatrician may just put them on birth control pills, you know, without clearly defining maybe what it necessarily might be. And then those are the patients that, you know, a lot of times end up in our office in their 20s and trying to get pregnant. And then we tell them that you've got PCOS, and they say, I have what? You know, but alternatively, you know, the sharper pediatricians will send them to pediatric endocrinologists who, you know, are pretty astute, and they usually figure out this patient has PCO or doesn't, you know. But again, those criteria I think are still in flux to a great degree, because there are so many subsets out there, 4 subsets really, that, you know, again, can confuse a lot of doctors, especially ones with normal periods, you know. And one of the other things that comes up a lot is, you know, the androgen levels. Androgen levels, when you're drawn sometimes in basic labs like Quest or LabCorp, they're not that reliable, especially the free androgen index. If they measure a free testosterone, it's usually not a reliable value. So actually, to really calculate what the androgen index is, or how much actual free androgen in the blood, you usually have to measure a total testosterone, divide that by something called the sex hormone binding globulin, and then you get, and multiply times 100, I believe, and you get a free androgen index, which is more accurate in terms of whether this patient really has elevated androgens or not in the blood, because you may not be able to detect that on the skin, for example.
So maybe a DHEA and total testosterone doesn't really show.
Well, I mean, it may not, you know, because total testosterone, it measures testosterone that's bound up in the bloodstream and not free in the blood. You want to also know what's free in the blood, and that's where that free androgen index I just described comes in.
Okay.
A DHEAS is another androgen that comes from the adrenal glands, and that can be elevated in about 15 or 20% of PCOS patients. It also kind of goes along with the syndrome. Why that happens, nobody's really clear, but
Okay.
it's something I routinely measure.
And so when we talk about, like what's the most common misconception and myth regarding PCOS, you mentioned women are not always overweight, but I think a lot of people associate PCOS with obesity or weight gain.
Correct.
What would you say to someone who said, well, I can't have PCOS because I'm thin?
Well, that's the point, is that there are
Mm-hmm.
subsets out there of PCOS individuals who are thin, and we see a lot of them in our practice, and they just usually have irregular periods or polycystic ovaries on ultrasound.
Mm-hmm.
So they qualify as having a diagnosis, but weight is not a criteria.
Mm-hmm.
And that's what confuses a lot of doctors out there who learned about this, and they saw the classic case in the textbooks. And again, they say you don't have PCOS. So,
Mm-hmm.
and they do. So I would say that if a woman is overweight, it may make the symptoms of PCOS worse, because the more overweight you are, the more insulin resistance you have, and that tends to make the ovary make more male hormone, and it makes the metabolic complications such as pre-diabetic issues worse.
Mm-hmm.
So, obviously those people need to be treated a little bit more aggressively. And I call those people more metabolic PCOS, while I call the thinner women nuisance PCOS, because it's usually related to irregular cycles or cosmetic issues. There's usually nothing that's going to necessarily change their lifespan.
Mm-hmm. Okay, so that kind of brings me to, I think, why is it important that women with PCOS are aware of the different types of those subsets? Because I would think that if you had one particular kind, like you're speaking about, without any metabolic issue, could there be a likelihood you would develop that later on?
Well, again, I would never say never, but I think the likelihood is lower in those individuals. But, I think I would rely also on history. If those people have a very strong family history of type 2 diabetes, I think
Mm-hmm.
that's a very important piece of history that we have to ask all our patients, because if they do, I think those patients we need to pay a little bit closer attention to, because even though they may be thin now, in X number of years, those metabolic complications may occur.
Mm-hmm.
If they don't have a family history of PCO, I think it's diabetes, then I think it's less likely they're going to develop a problem.
Okay.
So I think that those patients, while they do have insulin resistance by definition, are probably less likely to develop type 2 diabetes in later life.
And, when we read about epigenetics, it's interesting because certain genes can just switch on according to your environment. Yeah. So I guess if you're eating a lot of crap and, you are predisposed to having that gene for the PCOS, and it could typically make you have some metabolic issues.
I really think that's a very important point, I think, is that, I think that the diabetic gene or the insulin resistant gene there that's in the family is a very common thing that I see in people who have PCOS and are insulin resistant.
Mm-hmm.
It's very common, and those people, keep in mind, if they get pregnant, when they get pregnant, they're, very high likelihood they're going to develop gestational diabetes, which then, is basically an 80% risk of type 2 diabetes.
Oh, I see. Yes. And I mean, I would think that the more we read about what we can do to be proactive with this, I think it is important to educate women on how they can get tested, or just, to really pay attention to things that they can do to boost their success with ovulation and getting pregnant and all these different factors.
There's nothing like getting pregnant to motivate anybody. I mean, I think, even the men that come in, we tell them to stop smoking because it's going to affect their sperm. Well, that motivates them,
right?
Because typically most men, if they go to the general doctor and, doctor tells them, stop smoking, they're not going to do it.
Right.
But women for sure are usually much more motivated to do things, especially when it comes to pregnancy. So, when a woman isn't getting pregnant and their friends are, getting pregnant, or, their mother is looking at them cross-eyed and, and then saying, why don't I have grandkids already? And, that really gets them motivated. And then, especially if their cycles are irregular and it's not happening, within 6 months, they're usually in a doctor's office. And, if they're not in specialty offices, they're seeing their OBGYNs and already getting 3 or 4 cycles of clomiphene by the time they reach us.
Then I actually have a question about that. You hear so much about Femara now, which seems like it's replacing Clomid. And, so I want to know, as far as what you think, success rate wise with women with PCOS, who might benefit more from Clomid versus Femara versus somebody who's coming in who perhaps needs IVF? Like, how would you establish that?
Well, I think Femara is a great drug. I mean, we've been using it pretty much exclusively for PCOS for sure, because it seems like PCOS women respond better to it than they do clomiphene. So anybody with PCO usually gets Femara. I mean, the nice thing about Femara is it's got a very short half-life. It's out of your system in 48 hours, whereas Clomid has a very long half-life, about a month. The metabolites hang around. Why the FDA proved that, I don't know. I mean, because once the woman is pregnant, the half-life of Clomid is so long that the metabolites are still hanging around there. But apparently it has no effect. But it does thin out, or potentially thin out, the endometrial lining in some women, so that, because it's an anti-estrogen. Well, Femara does not do that. So it doesn't interfere with the endometrial development like we like to see when we monitor that in women that are trying to ovulate. But I almost use Femara almost exclusively in all my ovulation induction cycles. So I think it's pretty much replaced clomiphene to 90% from what I normally do, because I just think it's such a superior drug. I mean, the FDA has yet to approve it for ovulation, but everybody's using it off-label. And as long as the patient isn't pregnant when you start the drug, so it's very important to do a pregnancy test before you start the drug Femara, because it could cause birth defects.
Is this something that someone could get from their gynecologist, or do they need to see a reproductive endocrinologist?
No, I think the gynecologist can be, some are very comfortable prescribing it. I mean, it's prescribed very similar to Clomid. It's either 1 pill for 5 days, day 3 through 7, or, or 2 pills. Sometimes, the specialty people like us can sometimes go higher on the dose. But typically it's very easily prescribed by an OBGYN. And I've had patients come from OBGYNs who've had Femara for several cycles already.
Okay, and that's something that they need to be monitored? Like, would you want to do ultrasounds because of the increased risk of maybe multiple pregnancies, or is there a big risk with that?
Yeah. I mean, it's not tremendous risk. I mean, with clomiphene, it's only about 8%. So, with Femara, it's probably similar. But I mean, I think you always like to know, did the patient, make a follicle? And, I mean, you can measure, I guess, cycle day 21 progesterones. That's another way of doing it. But it's always nice to know what kind of response the patient got, and also to help them trigger ovulation at the right time when the follicles mature. So that either if they're having, regular intercourse at home, or whether we're doing an insemination, we have to do an ultrasound so we know. I mean, it's best to do an ultrasound so we know exactly when to, time the IOI or relations. Okay.
And then what do you see as far as success rate wise with that?
Well, Femara, I mean, it depends again on the patient. I think the success rates are nowhere near IVF, of course. It's probably around, 15% maybe per cycle, something like that, reasonably increased over, regular, because, I mean, normal relations at home, you probably got about a 5% chance per month. So we can increase it or double it at least, and maybe increase it more with IUI. So, I mean, I'd say 3 cycles, if you're not pregnant, I'd say by 3 cycles of Femara or Clomid, it's usually around a 20-25% chance of getting pregnant. And if after those 3 cycles, I think particularly with Clomid, I wouldn't use more than 3 cycles of that. But Femara, you could probably push it a little longer. I'd say 3 or 4 cycles of Femara. If you're not pregnant, I would move it up from there.
Okay. And I think I've noticed that too. It just seems like there's a lot fewer side effects with the Femara versus the Clomid.
Yeah. I mean, they're usually short-lived kind of side effects, but, people do complain about it a lot. The moodiness, and they read about it. So already they have it in their head they're going to get side effects from these drugs, and a lot of times it's just not there.
And what kind of, I guess, since you work with PCOS so much and you work in a reproductive clinic, what sets your treatment apart from other clinics, would you say, or doctors?
Well, I think, we have a lot of individualized care. I think that's part of our success. I think, we see the patient sees the doctor through the whole course of treatment pretty much, as much as we can be there. Certainly during the IVF process, we're there with the patients as much as we can. I think if we talk specifically about IVF, it also comes down to the team approach. It's not just the doctor. We have really good embryologists, and our clinical staff obviously is very dedicated. So I think it comes down to a team approach. And cautiously counseling the patients on success rates and things like that, and what to expect. As far as IVF is concerned, we're careful about stimulating these patients. We're obviously trying to avoid complications like hyperstimulation syndrome, things like that. But it comes down really to, I think, the team approach, and having good support staff is part of it too, and also just having the experience of doing a lot of this.
Right. I mean, that is something that it can be pretty traumatic for someone who's been through an IVF cycle, who's hyperstimulated and ended up, in the hospital perhaps,
that's it's not like we don't get it anymore. I mean, we do get some cases. I mean, they generally tend to be milder and self-limited. I mean, and one of the ways that we tend to avoid that is not transfer anybody with PCOS in a fresh cycle, because typically with PCO, when we're doing IVF now, their estrogen levels tend to get pretty elevated, and as a consequence, we don't want to risk hyperstimulation syndrome with them, number one, but also because the lining of the uterus probably gets abnormally advanced from that really high estrogen level. And some of these people don't get pregnant in the fresh cycle because we think maybe it has to do with an implantation effect. So with PCOS and also endometriosis patients, I never transfer in the fresh cycle. And then to ovulate these patients, I typically use what's called a Lupron trigger, which is a GnRH agonist, which causes the patient to have their own LH surge, essentially. And the half-life of that is very short, as opposed to the old way of doing this, or the other way of doing this is HCG, which has a long half-life and hangs around and tends to, exacerbate this tendency towards hyperstimulation syndrome.
Interesting. So the fresh cycle with IVF is basically what we're talking about when someone is stimulating, going and getting a day 5 embryo, or in your case, I know you guys only transfer day 5 or day 6 embryos, and going straight into the transfer versus freezing the embryos, and perhaps looking to see if, I know that now you've been doing an endometrial receptivity test that some of our patients have had done.
Yeah, I do a lot of frozen embryo transfers. I tend to transfer, I'd say, probably 90% of my patients are doing frozen embryo transfers, and probably a lot of them are doing PGS, or pre-implantation genetic screening, so that would obligate a frozen transfer. But there are ways now to also improve implantation in these patients with this endometrial receptivity assay, which I think is probably a topic for another day, but it's also a very good way of helping these patients. But PCOS patients would qualify because a lot of them are doing frozen embryo transfer cycles. So if they wish to do something like that, we discussed that with them at the time.
And I would say with PCOS, it would be an advantage, I would think, if you had a lot of embryos to really find out how many of them are viable and how many, instead of doing transfer after transfer, I guess.
Yeah,
So
I mean, I do mention it to them as a proactive test, because typically that was used as somebody who's failed a frozen embryo transfer, and we don't know why, and then we found out that they had, that they needed an extra day progesterone, or they needed 1 day less. So it kind of, I think, is useful as a proactive test rather than somebody who's already failed frozen embryo transfer cycle.
And I mean, that brings us to why the number one reason why most women with PCOS fail to succeed in getting pregnant. I would think it has to do with ovulation, or perhaps getting to that point. So that's
I mean, a lot of women come in, and one of the things that I think that women have to be carefully told, I think, by doctors and specialists such as yourself too, is that they read out there, oh my God, I have PCOS, I'm never getting pregnant. I've already read that I can't get pregnant, and I'm going to get heart disease and die.
Okay.
And a lot of things are out there. And then, I think that probably contributes to the higher risk of depression and anxiety, which we should mention is more common in PCOS women than not, because of probably some of this information that's out there, that they're never going to get pregnant, they're not going to have a normal body size or style, lifestyle. They're going to have diabetes, they're going to have this or that, they're not going to ovulate, whatever, and cosmetically things will never improve. So a lot of these people do need support that way. So but I think when women come in and they tell me this, I think we can allay their fears and say, listen, we have very good techniques these days to help you. And one of the things I think that a lot of these women probably will, should be on is metformin, which we should discuss. I think that's a drug that's helped a lot of these women, substantially. Particularly it seems, anybody that what we think has insulin resistance, they should be on metformin right away. And they should stay on metformin through their pregnancies, I think, to help reduce possibly gestational diabetes, and it may even reduce the risk of type 2 diabetes later on. There's been some studies on that suggests that may be true. And it's a pretty safe drug. It's a class 2 drug. It's like taking Tylenol in pregnancy. So I think metformin is a good drug, and particularly, and even in the thin women who, you don't think have insulin resistance. I mean, some of these people, are probably prescribed clomiphene or Femara as first line, which is fine. But I always add in metformin because I think it helps those drugs work better, and I think it helps improve the egg quality a little bit.
So even if you are not insulin resistant, would that be something to ask about?
Well, the point is, who is insulin resistant, who isn't? Okay.
Right.
I don't think it's so easy to tell. I think sometimes it's easier to tell than others. Obviously, if the blood sugar's high, or they're pre-diabetic on a hemoglobin A1C measurement, that's elevated, or I think that's obviously good evidence. But insulin levels may be unreliable, and a lot of doctors follow an insulin to glucose ratio, and I don't think those are too reliable. And then they say 85% of women who have PCO, whether you're obese or not, are insulin resistant. By definition, if you have PCO, you have some sort of insulin resistance. And as evidenced by the fact that some of these thin women, we put on metformin, and if you give them long enough on it, they'll start to cycle, and probably 20-30% of them are going to get pregnant on their own.
Interesting. Yeah. So that we see that some women do really well, but others have a lot of nausea when they first start out.
They have to go very slow. Yeah, and the ER variety of it, the long-acting variety, seems to help a lot.
Okay. And, I guess some people will try it for weight loss as well. Have you seen that to be true, or does it help with that?
Yeah, I don't think it hurts. I mean, it's not a weight loss drug. It's not approved for weight loss. but some people sort of get a little of what's called an anorectic effect from the drug, and they feel kind of I don't want to
because they're nauseous.
Yeah,
Could be it.
yeah,
Okay.
yeah. So they they say they tend to eat less, or they tend to feel fuller.
Okay.
So it might be useful in that standpoint, and some people do get a modest weight loss effect from it. But that's not to say that if you have an obese person who who really needs to lose weight, that the doctors, not so much our practice, but other physicians shouldn't prescribe weight loss drugs. There are some pretty good ones out there now that they could use. I mean, that's definitely something to consider.
So what are some specific roadblocks to watch out for with PCOS?
Well, I think, probably an overdiagnosis, that somebody thinks they have it and they really don't. I think those things, that's why I was trying to mention the different subtypes out there, and, people who were diagnosed maybe, prematurely, and some of the roadblocks may be that some people really have PCOS and they never really were diagnosed. And that, some people around the time of menopause, they figured, oh my God, I don't have PCOS anymore. I went through menopause. But now the transition becomes, in some of those people, a metabolic disease rather than a reproductive disease. So I think that at some point there's a transition for some of these people who, obviously are worried about childbearing and less likely about metabolic complications at that point. And then later on, they do have to worry about, as you go through menopause, your body changes. You become less lean, your adipose increases, and, your muscle mass decreases, and insulin resistance starts to increase more. So it becomes more of a problem at that point.
That's interesting, because sometimes you hear doctors say, well, they don't have PCOS anymore. They're over 45 and, so how could that be? Does it just magically disappear after a certain age, or does it get better?
Well, no. Well, the ovarian or the reproductive part may be less, but if you can include the metabolic component here with it, which we know is a complication of PCOS, then they still have it. But they're considered maybe pre-diabetics or type 2 diabetics at that point, but they may have had underlying PCO all these years and may or may not know it.
And I think that brings me to my next question, which would be, what's wrong with waiting to address PCOS symptoms, and what consequences can this have? Because so many times we see pregnant women as well in our practice for acupuncture, and we do see them come in with untreated PCOS. So perhaps they conceived on their own, but they were never told that they might have this, and they did spontaneously get pregnant without any treatment. But now they're running into gestational diabetes, and they are coming in a little bit perhaps overweight, and and then there's a lot of mood swings and different things like that going on due to hormonal changes. So what are the consequences of the underdiagnosed, I guess you could say?
Well, again, I think these people, again, if they don't come to medical attention, or if they're not bothered by any of their symptoms, it's going to be very hard to do anything about it. And then obviously, yes, they're going to show up pregnant, some of them, and then we're going to have to tell them. And some of these people are going to become diabetic, and they may become diabetic sooner rather than later, and obviously we're going to have to deal with that part. But I think, again, the main people that we see aren't so much that. I think those people usually come to medical attention at some point. But I think the ones that aren't properly diagnosed initially, maybe, who have been on birth control pills for many years, and then all of a sudden show up and are trying to get pregnant, I think those are the ones that I tend to see.
Yes.
And then we diagnose them at that point, and they say, well, I have what? I don't know what you're talking about. And
it's a little bit of anger too. Like, how come no one told me? I could have been doing something about this.
Well, it goes back to, probably, the younger years when some of these people are put on, birth control pills as a teen, and they're just left on it, and they're doing fine. They're happily cycling. They don't have any cosmetic issues, because birth control pills usually work pretty well for the most part. and they're getting a regular period, and they're going through their life, and then all of a sudden there's a stumbling block because they go off birth control pills and they don't get a period, or they're not ovulating, or something sort of clues us in that they have this issue, and then you're right, can create stress and anxiety and anger. But I think and that becomes a tricky problem because, again, diagnosing these people too soon, may result in a misdiagnosis too. So I think it's going to be an individual case. Like some of these women maybe will get seen sooner, maybe in their early 20s, and maybe at that point, doctor will take them off birth control pills and say, "Why were you put on this in the first place?" I think physicians need to have a little bit of curiosity too about some of these people.
That's a great point. I mean, I wonder if they could suggest perhaps maybe taking a break from birth control sometimes.
Yeah. Well, some people are going to do that. Some people aren't. I mean, it depends on the person.
Right. Well, I guess when they come to us, we're like, well, I would love to know what your period's like, like what it looks like if you've been on birth control for 10 years.
Yeah, they don't know.
Yeah.
They don't know.
And so I know that you do recommend supplements sometimes for your patients, and I know with PCOS there can be a lot of information out there on what's good and what can help. But if somebody's coming to your practice and maybe they're suffering also from poor egg quality as well from the high testosterone levels over the years that they've had, would you still? I mean, I know DHEA would probably be out of the question, but for a lot of women with PCOS, I think it's not a good recommendation because it could cause their androgen levels to get even higher and raise the testosterone. But perhaps would you still recommend some antioxidants and some?
Absolutely. Absolutely. So, we usually, obviously, prenatal vitamin, but we'd obviously put them on other things. Like some people use D-chiroinositol as one thing that has a very similar action to metformin. Some people that can't take metformin, I put on D-chiroinositol, and that's an over-the-counter supplement. And actually, in some people, it works pretty well. Actually, it's available as Pregnitude.
Pregnitude, yes. We love inositol here. We put everybody on inositol. It's just it's one of those things where there's no side effects to it. It's a B vitamin derivative, and it can help even putting it in your smoothie. We have it in powder form here that it's tasteless. So there's been a lot of research on that, and I've noticed more and more IVF clinics using it for their patients too.
I think there's some value to taking that. It's certainly not going to hurt them. Other antioxidants, I know our nutritional people put them on a lot of different supplements, and the people that see our lifestyles consultants, they're very into these different supplements. And one of the things that we do with PCO, besides, what I do when I see a PCOS patient, is there are panels of, it's called an inflammatory panel, because now we know that PCO or insulin resistance it causes inflammation. That's really how it causes a problem. It causes inflammation in the body and obviously in the blood vessels. So there's various tests that we look at, including like glutathione would be one thing, and CRP, looking at the elevated CRP levels and other inflammatory mediators that might tell us that this patient has insulin resistance, maybe more so than looking at insulin levels and glucose levels. So that sort of goes along with some of the laboratory testing we were talking about before, that looking at panels of inflammation is also valuable, because those people we can treat with supplements to lower their inflammatory index and help them that way. And actually metformin is one of the things that we would use if we see elevated inflammation.
But then that's great. It has a preventative effect for heart disease as well then. Okay.
Yeah, I think it is. I really do. And as a matter of fact, metformin, I read an article that are looking at it as an anti-aging drug in general. So it's being looked at, and even as a breast cancer preventative.
Oh, interesting. That'd be interesting to read about.
And Alzheimer's disease too.
Wow, it does everything.
Yeah, apparently.
Well, and you mentioned that you have a lifestyle consultant there who is a nutritionist, perhaps, that works with, and we hope to speak with her soon too. And how important would you say an integrative approach is with PCOS?
Well, I think one of the things that, I was just at the ASRM meeting in San Antonio, and I attended one of the PCOS conferences there, and to see what was new. And while there's nothing, novel that's come out, drug-wise for PCO, one of the things that I think I did take away from it, that an integrative approach for PCOS patients is the way to go. And a lot of places around the country have, several specialists on basically seeing these patients all at once. So not only a physician, maybe an acupuncturist, a nutritionist seeing the patient, a psychologist seeing the patient.
That's great.
And a weight loss specialist in those people. So somebody that gives weight loss drugs, and and also a surgeon on staff to do any kind of weight loss surgery. And so they have all aspects of their care sort of tied in together. And I think those patients are probably going to do very, very well. I mean, I haven't read that full study on this yet, but it seems like the way to go. So a more integrative approach, not just seeing the physician, physician telling him to go on a diet. I think they need other specialists involved in care.
That's wonderful. So there are places that exist such as this.
I think it's University of Texas that has that. Yeah.
That's great. Well, I know that IVFMD does a pretty holistic approach as far as incorporating all those things as well.
I think one of the first ones to really do that, I think, to have, we have two very fine nutritional people on our staff. One's a physician, actually, and Martha is the other one who's, like a PhD. And she they're both very, very good and very, very knowledgeable people. And they really help people a lot. So I find that, that those are valuable referrals.
That's great.
And to people like yourself who will really help them too.
I think it's great to have everything, the communication too. If you are out there looking for a provider and, you'd love to have your reproductive endocrinologist understand what type of supplements you're taking, or maybe reach out to your nutritionist, and then also, communicate with your psychologist. It really does take a village sometimes with PCOS. So I think that's important to have a great team.
Oh, absolutely. Absolutely. Those are the people that do well.
Right, and just going into a pregnancy feeling phenomenal, I think would be great.
With tremendous support from your whole team. I mean, that's the way to go. And so one of the things that we try to focus on, again, going back to maybe why we're more successful, is that we make sure that the patient is as healthy as can be before they really try to get pregnant. So one of the things we'd like to also emphasize is that if their BMI is high, we'd like to try to get that way down under a realistic level before they even try to get pregnant, to reduce their risks of complications in pregnancy. And we make sure they have a lifestyle consultant evaluation and or psychologist or whatever they need, at that point. So I think it is something that we are very, I think, trend setting on, if I might say. I think we kind of look for those things ahead of time rather than deal with them later.
That's a preventative approach that I think works wonderfully well. I'm sure everybody will be interested in getting those links if we find links to places around the country, perhaps that actually have these type of programs in place. But I'm going to also post on a link on how to contact you as well. And I think this has been wonderful information. And for anybody who's really struggling out there, who wants to, search for somebody who actually is specializing in PCOS, who works with infertility, they can go to IVFMD.com and they can, look. You have several locations around South Florida. I know that, but I know you guys treat a lot of patients from out of the country as well, and all over. So you can get information there. And also on our website at floridacompletewellness.com, we have resources as well as a IVF handout on how to prepare for IVF and a guide there to kind of look at some of the supplements that we talked about as well, and then see what's helpful there. So it's been a pleasure speaking with you tonight, and we really appreciate you coming on and sharing your knowledge with us.
Thank you, Flora. Thank you. It was great. It was great to be here.
Great. Well, thank you guys for joining us, and I hope to hear from you guys soon. Have a great night.
Thank you.
Bye. Bye.
Thanks for listening to the PCOS Revolution podcast. Be sure to visit us on Facebook and Instagram to join in the conversation, access the show notes, and discover our fantastic bonus content. If you love the PCOS Revolution, we'd love for you to subscribe, rate, and give a review on iTunes. Until next time, beautiful ladies.